Hello, everybody. Our speaker is Jeannie Gorman. She's a leading name in autoimmune and digestive health. She has a master's in human nutrition, functional medicine, and has spent over 12 years in functional and private practice. She consults globally with clinicians on functional testing at Doctor's Data. Jeannie is here to unpack the essentials of GI microbiome testing for improved patient care. At the end of her presentation, if time allows, Jeannie will be fielding a few questions from the chat, so please drop your questions there before the end of her presentation. Please join me in welcoming Jeannie Gorman.
Thank you, Lisa, very much for allowing me to be part of such an amazing event. I love talking about GI testing because it's so critical to your patients' not only symptoms, but overall systemic health. So hopefully we will make that real clear today for you. So it's going to be an introduction to comprehensive GI microbiome testing. Some of it may be newer to you, some of it may not be newer, but hopefully it's a good review for everybody involved. Flipping through. Okay. So these are sort of my talking points of what we're going to cover today in regard to GI microbiome testing. Why do we test? Where do we test? When do we test? How do we test? And what do we identify as clinically significant in the stool testing? So the why and the where of it is that the why is that, of course, you've heard that that quote from Hippocrates saying that all disease begins in the gut. Beyond this, there are other researchers throughout history that have connected the not only the gut brain, the gut health, the gut heart, all of that leading to sort of systemic issues with the patient when we really should be starting with that gut discovery. In the GI microbiome testing, we are mostly concerned with these organisms, the bacterial community. The community consists of beneficials. There are a group of research-based expected beneficials that should be found in the microbiome in a sufficient quantity, I'll call it. Commensal bacteria that are doing a job, they have a role in the microbiome, they're just not listed as beneficials. Dysbiotic bacteria, which usually are commensals that have risen to the elevation of dysbiotic and could require treatment. And then pathogenic bacteria, obviously problematic, disease-causing severe symptoms, etc. Then viruses live amongst the microbiome, the yeast, the fungi, the parasites, and other constituents of the gut that are important to know about. Oops. Oh, sorry. So when we are testing in the microbiome for stool testing, obviously we are looking at the large intestine. That is where we focus. Patients may or may not experience symptoms that relate to a large intestine overgrowth of some kind or an underabundancy of some kind. So it can be deceptive if you're just going off the symptoms. These are a list of the typical patient cases that you might strongly consider microbiome testing. The chronic metabolic conditions like diabetes and any other metabolic syndrome, immune dysfunction or insufficiencies, chronic inflammatory diseases, of course, mental health conditions. So remember that gut-brain axis. Any known GI diagnosis, of course, you want to keep track of that patient and how the microbiome is doing. Any low soluble fiber diet patient. So consider all of the low FODMAP patients out there or the standard American diet patients that are out there, apart from the more specialized ketogenic or vegetarian lifestyles. You may have a vegetarian and you think that their microbiome has got to be good, but I have over and over come across vegetarians who are not sufficient in their microbiome and they're not taking in the right soluble fiber aspect to support the enterocyte. Fertility patients and hormone patients, of course, obesity patients, those using the GLP-1 or 2 agonists, Liver, even liver, adrenal, and thyroid patients could also benefit. And then, of course, that patient who could be an athlete or could be just looking for optimal health and longevity, that would be a perfect person to ideally test once a year just to see how we're doing. So Doctors Data has a test called GI 360. It is sort of the best of all worlds. Of course, we offer the comprehensive stool analysis with parasitology and other profiles, but this profile combines the best of all worlds, really. Offers PCR detection of beneficial microbiome. We have microscopy, microbiology, and a host of other stool chemistries that we cover for digestive health, inflammation, short-chain fatty acid production, beta-glucuronidase production, etc. So ideally, we are covering all of the gamuts cross-referencing, which is important, we'll talk about that, to give you the most clinically actionable results. What is PCR? You may or may not be aware of what PCR is. It is a molecular biology technique. We're basically looking for the DNA of organisms. So in the case of the GI 360, we're looking not only for the expected beneficial DNA of about 50 species, we're also using PCR detection for pathogens. So pathogenic bacteria, viruses, and parasites. So what makes PCR so special? Why is it different? How is it different than culture? Well, with PCR, we are using a probe, very susceptible and specific probe to the DNA of that organism. So you are excluding all other organisms to identify an organism. So it's very specific, very accurate. It is EU approved and FDA cleared probes. So very important to have an accurate probe. PCR is like a fishing hook in a pond. You're going to use a specific hook with a specific bait for a specific fish. Versus culture. Culture is more like a wide net. It's gonna catch what's there. So what is there is the question on culture. And then on PCR, is it there is the question. So good to have both, which is what we do. The GI 360 then moves into the realm of comparing your patient's results with a normal biotic result to identify how dysbiotic or normal biotic your patient is. So we give you the data of each of the species, but we also give you sort of the interpretation of how poor or how good your microbiome, your patient's microbiome is. We score the dysbiosis level. Ideally, on the GI 360, we are looking for a low dysbiosis index, meaning low dysbiosis. On the diversity score, we're looking for a high number, so a 4 or a 5 on the diversity score, a 1 or a 2 on the dysbiosis index. As we are evaluating the beneficial microbiome, it gives us a sense of the abundance and diversity of this group of beneficial bacteria. It is influenced by diet, age, antibiotic use, and other factors such as food hygiene, living environment, and exposure to any exogenous microbes. Normobiotic versus dysbiotic. How balanced is the gut microbiota? In other words, when we are assessing the beneficials, we are not going to be eradicating. We are just looking for the balance. Where is there an overabundance and an underabundance? The imbalanced microbiota may be associated with an IBD patient, IBS patient, the diabetes patients, and the obesity patients. What is next? What keystone bacteria are we looking for? As I mentioned, we're looking for about 50 different species. They're all listed on about 2.5 pages. We are identifying the levels found of the DNA. So in this page, you see the yellow, the blue, the green, and the red. Those are colors used as indicators for you on that species. Green would be normal. Yellow would be 1 standard deviation away from normal, either high or low. The red would be 2 or 3 standards too high. Blue would be 2 or 3 standards too low. So ideally, a normobiotic microbiome is going to be mostly green and a few smattered yellows here and there. But this is an assessment for you and very specific, targeted, very specific to species. The keystone bacteria that we are mostly concerned with would be the bifidobacterium species, lactobacillus, both of those found heavily in probiotics, and go right to the large intestine in terms of what needs to be there. The Faecalibacterium prausnitzii species is also an interesting species that shows up on our GI 360. Very much associated, we'll talk about all these, but very much associated with the health of the butyrate production. Akkermansia muciniphila, also identified on our GI 360. Very up and coming in the research, the peer-reviewed literature. We'll talk about that. Proteobacteria phylum itself is a more aggressive grower when there is inflammation in the gut. So you may have a high level of Proteobacteria phylum in general for that high inflammation patient like IBD. And then the Phascolactobacterium species, also relevant to the patient's history, the patient's symptoms. It's good to see that if the patient is struggling, say, with their weight or struggling with constipation, some of that may lie in what's going on in their microbiome. So taking the deep dive is very interesting. Bifidobacterium, just briefly, we all know that from today's probiotics, very important in the large intestine, responsible for the production and the absorption of the B vitamins and K2. So if a patient is low in bifido, you may assume, if they're not already taking B vitamins, they might need a B complex or K2. Very commercially available. The Firmicutes phylum meaning a group of bacteria responsible for the manufacture of butyrate. Butyrate is very essential in the microbiome. I call it the oil of the engine in the gut. So very anti-inflammatory, very, very essential with the fermentation process that needs to take place in the microbiome. These species are all identified and are the butyrogenic species found on the GI 360. The Faecalibacterium prausnitzii, very important species also for, it's one of the key butyrate producing bacteria. So when a patient is low in their Faecalibacterium prausnitzii, it tells me that their diet has not supported a soluble fiber intake enough to support this species. So soluble versus insoluble, always looking for soluble fiber for the microbiome. There is a place for insoluble fibers, so the vegetable fibers and the flax seeds, but we're really looking for water-soluble fibers. Lactobacillus, another cornerstone species found in probiotic. Very often I see a low lactobacillus, so of course we're going to apply probiotic and the soluble fiber to support that. The Akkermansia muciniphila, as I've mentioned too, this is the more up-and-coming species in the literature. It's associated with the mucosal barrier. It's got mucin lover in its last name. So muciniphila, mucin lover, helps to not only replete, but deplete in a good way, the mucosa. So when it's depleting the mucosa, it's encouraged to create new mucosa. So that's all very important for the health of that gut lining. Also associated in the literature, sometimes referred to with weight management, immune system support, and several other areas of interest. So now we're at the how. So how does PCR work? We're looking for beneficial bacteria, remember, and pathogens. So we've already gone through the beneficials. These are the pathogens. Looking for pathogenic viruses, bacteria, and parasites. Again, very specific technology. We also would offer cultures. So we're looking for the comparison of a PCR detection for a pathogenic bacteria and then a culture of a pathogenic bacteria. Well, why? Because the cross-referencing of that is important. Sometimes you can get a positive PCR detection with old DNA or very subclinical levels of DNA, past exposures, not causing symptoms, not causing infection, just sort of inhabiting the space. If you find that same organism positive on a culture, obviously that would be an active infection and you would likely have symptoms. So it's a good cross-reference. Of course, we would not test PCR pathogenic bacteria. We would not treat that without symptoms. Parasitology is the next offering and an important offering in any stool test. We're looking for ova and parasite. We have about 50 species of ova and parasite that are listed. The more interesting finding would be one of cysts. If you find a parasite that has a cyst finding, that is a little rougher to get rid of. They sort of form this concrete barrier around themselves. So it's good to know that that is what we're looking at. It's under the microscope, using the naked eye, full-time parasitologist at our lab. Other markers on parasitology include yeast. A dead yeast finding can be helpful with some symptoms. White blood cells, red blood cells, Charcot-Leyden crystals related to parasites as well, fibers, etc. Next is the microbiology culturomics. So I encourage you to Google culturomics and see how important that is for the microbiome. Very interesting information out there. We're culturing bacteria and yeast using our identification method of Maldenhof, which is a very specific identification library of many, 1,200 organisms that we can identify. This is an example of what you would see on the culture page. Pathogenic bacteria that I mentioned would be cultured. Imbalanced, I've already talked about imbalanced bacteria, not listed as beneficials, but still important in the microbiome. And then any dysbiotic levels of bacteria and yeast, of course. The beauty of doing cultures is that we can then offer you sensitivity testing. So what is sensitivity testing? It is great because we're guiding your treatment. We're not giving you just a wall chart of this organism, this product. Your patient's stool in vitro with natural and pharmaceutical agents, and we give you the efficacy levels of those agents. Stool chemistries, finally, is several different areas, starting with digestion absorption. That is a great measurement, especially for the elastase, which is an exocrine pancreatic sufficiency marker. We have inflammation markers. Some are very specific to the IBD patient, but can also relate to non-IBD situations like food sensitivities with the lysozyme or an organism with the lysozyme. We also cover secretory IgA, very, very important in the microbiome to alert the immune system on any invaders or problems coming down the GI tract. Butyrate is assessed, total short chains assessed, again, very important to the oil of the engine is what I call it. pH levels, beta-glucuronidase is covered, and also occult blood. So in conclusion, testing and addressing would be the theme here. There is a world of good to be done, especially with a patient who's been through many doctors and symptoms are still there. Nobody's found anything. I encourage a deep dive into the microbiome because different pathologies present different symptoms. We evaluate and support the keystone bacteria, obviously the bifido, lactobacillus, and the soluble fiber, because you're not going to get probiotics for every specific organism that we need improvement on. So we rely on those cornerstone species. So the GI 360 also covers PCR detection, the parasitology, and those stool chemistries. It is really a functional approach to stool testing that you can have immediate results with to treat patients 2 hours later if needed. And here are my references. Thank you very much for coming today.
Thank you so much for your talk. Now we're going to start the Q&A portion of the session. If anyone out there has a question they've been holding on to, you can post that in the chat to get us started. I was wondering, do you always need to treat pathogens or parasites if they're detected?
Good question. The literature does not support treatment of pathogens, so disease-causing bacteria, virus, or parasites, because PCR, just like with COVID, we learned that it can be positive without symptoms. So symptoms would be important for treatment. And then we offer, of course, natural agents. It's not susceptibility testing, though, for pathogens. We defer to what is out there with standard of care, whether it's pharmaceutical or sometimes there are natural agents to address some of the pathogens.
Okay, thanks. How often do you recommend repeating GI testing?
In terms of
And on a patient, is there any indications you'd look for that someone needs to redo it? The microbiome is so changeable. Just wondering.
It is changeable.
Yeah.
It's amazing what happens in a couple of weeks. Well, in terms of treating, if you find something to treat, we suggest going through the treatment process, or however many weeks that is. We don't dictate that because we are obviously in vitro. So you go through the treatment process, you come off of treatment and probiotic if they're on it, and any exogenous fiber, anything to support the microbiome or eradicate something in the microbiome for 2 weeks, and then retest after that. And we have very specific profiles. You don't have to go back to the GI 360 if you don't want to. You can go to a smaller panel.
Okay, thank you for that one. Is testing recommended in the case of skin conditions like eczema or atopic dermatitis?
Absolutely. Absolutely. I would definitely recommend anyone with any idiopathic dermatitis to look into what's going on in the microbiome. A lot of times, not always, but a lot of times there is some organism at hand, and a lot of times it's yeast.
Okay, thank you. Just toggling between chat and Q&A here. Oh, we have a question about zonulin. Is it recommended to combine stool testing with testing for zonulin? I'm not sure the sample type referring to, but maybe you can comment on that.
Yeah, if you feel that the zonulin is the gold standard for intestinal permeability. So if you get a positive zonulin, of course, you're going to support that. You're going to find out why the patient has an impermeability issue. Could be an organism, could be a food. So you're going to mitigate the problem first and then support the microbiome with something like L-glutamine. But we don't include it because not everyone needs it. But yes, if you feel like your patient is reactive to a lot of foods, it might be an impermeability issue as a rule.
Okay, awesome. Just checking the time. We have a couple more minutes for questions. So we're getting some questions about what's the difference between similar tests that are available on the market. So, for example, what's the difference between a GI 360 and something available from Thorne, for example, or the GI map? If you could just comment high level on how people should think about the difference between those tests.
It's a good question. I am intentionally naive to other stool testing, frankly.
Okay.
It's just not fair. It's not a fair assessment because I'm so biased.
Okay. So understood. We've got a question about the difference between a finding of red blood cells and that of occult blood. Can you dive into the difference a bit more there?
Yes. Red blood cells, not usually, always coming from somewhere lower down. Could be a hemorrhoid, undiagnosed hemorrhoid, unknown hemorrhoid. Could also be rare meat, frankly. Could be some menstrual blood involved, but occult blood is really a GI bleed higher up. So very different. We would want to definitely follow up with a retest of any occult blood finding, and 2 or 3 of those positives would warrant a referral out to a GI specialist. Red blood cells will usually come as part of the package with the constipated patient.
Okay, awesome. That is the end of our Q&A session. Thank you, everybody, for posting your questions. If we didn't get to yours, we'll make sure we follow up with an answer. And for the folks asking about slides and specifically seeing your reference slide, everybody wants to have a look at that. The slides are available for download now, or we'll get them when the recording's made available. So please join me in thanking Jeannie for sharing her insights and knowledge with us all. Thank you so much. Now, stay tuned, everyone. Up next is a keynote session on transformative strategies in metabolic health. And following that is our closing panel discussion, where we'll be looking at the future of whole person care. Thank you all for joining us today, and have a wonderful rest of your day. Thank you.